everyone, welcome back to the second video of this week lecture. In this video, we are going to discuss the second type of the drug classification of adverse drug reactions, which is the DoTS system, as well as the factors that affect susceptibility to the ADR. In the first video, we have discussed the Rowland-Thomson classifications. In general, this classification is based on properties of the drugs and the reactions, which further classify as type A, type B, type C until type F. In contrast, the DoTS system, which are based on the DO, which refer to dose relatedness, T is time relatedness, and S is patient susceptibility. So this DoTS classification provide a useful template to examine the various factors that both describe the reactions and influence an individual patient's susceptibility. The DoTS system first consider the dose of the drug because of many adverse effects are clearly related to the dose of the drug used. For example, increasing the dose of cardiac glycoside will increase the risk of digitalis toxicity. In the DoTS system, dose relatedness can be further divided into toxic effect, which is the effect that related to the drug use outside of their usual therapeutic dosage. Another one is the collateral effects, which is the effect occurring within the normal therapeutic use of the drug, as well as hypersusceptibility reaction, which is the reaction occurring in subtherapeutic dose in susceptible patient. The time course of drug present at the site of action can influence the likelihood of an adverse drug reaction occurring. For example, rapid infusion of furosemide is associated with transient hearing loss and tinnitus. The DoTS system categorizes ADRs as either time-independent or time-dependent reactions. In the time-independent reactions occur at any time within the treatment period, regardless of the length of the course of time. Meanwhile, time-dependent reactions range from rapid reactions, immediate reaction following exposure, to reactions that are delayed. The final aspect of the DoTS classification system is susceptibility, which includes factors such as genetic predisposition, age, sex, altered physiology, disease, and exogenous factors such as drug interactions, which we'll discuss much deeper after this. As a pharmacist, these parts are crucial. Awareness of the factors that increase the risk of ADR is the first key to avoid or at least reducing the burden on the patient on the adverse drug reaction. In general, the main cause of the ADR due to the physiological changes of the important organ system for drug use. The main one are the liver as well as kidney functions. Reduction in hepatic and renal function substantially increase the risk of ADR because most drugs are metabolized in the liver and being excreted in the renal. So, impair of these two organs will impair the drug pharmacokinetic, which will be the main cause of the adverse drug reactions. The liver is the main organ of drug metabolism, so it is the most vulnerable to adverse drug reactions, especially when the patient experiences liver disease that may have complex effect on drug clearance, biotransformation, as well as the pharmacokinetic. In the cirrhotic patient, which is one of the liver disease, may precipitate the brain encephalopathy when taken the opioids or any sedative medications. In the renal disease, have complex effect, especially on the drug clearance. So they require dose reduction, and you need to monitor the creatinine clearance prior initiating any treatment, especially the drug that be excreted in the renal. Age is one of the key factors and important factor which affect the occurrence of adverse drug reactions. Elderly patients with multiple medical problems who are taking multiple drugs, those who have a history of adverse drug reaction, and those with a reduced capacity to eliminate drug are at high risk for adverse drug reactions. Meanwhile, neonates have different body composition, metabolism, and other physiological parameters as compared to us normal adults, which can increase the risk of specific adverse reactions. Neonates have immature renal tubular function when they are aged below of 8 weeks, so avoiding digoxin, aminoglycoside, ACE inhibitor, as well as an NSAID is a must. Physiologic hypoalbuminemia in neonates affect the drug dosing, so caution is recommended when dealing with high protein binding drugs such as NSAIDs. Neonates also have low body fat, which might affected by fat-soluble drugs, and it will increase the anesthetic effect due to immature blood-brain barrier at less than 8 weeks of age. The biological differences of male and female affect the action of many drugs. The anatomical and physiological differences are body weight, body composition, gastrointestinal tract factors, liver metabolism, and renal function. Women, in comparison to men, have a lower body weight and low organ size, as well as more body fat, different gastric motility, and lower glomerular filtration rate. These differences can affect the way the body deals with the drugs by altering the pharmacokinetic as well as the pharmacodynamic of the drugs, including the drug absorption, distributions, metabolism, as well as eliminations. Women are overrepresented in reports of toxicity associated with cardiovascular drugs such as sotalol, as well as erythromycin. So erythromycin is one of the antibiotics. This increased susceptibility in women is thought to be due to their prolonged Q3C interval compared to the men. Low expression of cytochrome 2C9 allele associated with poor metabolism occur more frequently in white individuals compared to black individuals. This has a potential effect on warfarin metabolism, which will cause increase the risk of toxicity. The presence of HLA-B1502 allele is highly associated with the outcome of carbamazepine-induced Stevens-Johnson syndrome, or known as SJS, as well as toxic epidermal necrolysis, or known as TEN. The presence of human leukocyte antigen allele, or known as HLA-B1502 allele, for which genetic testing is already available, indicates an increased risk of skin reaction for carbamazepine, phenytoin, as well as lamotrigine. Thus, FDA has recommended HLA-B1502 screening before using this drug, especially in Southeast Asian individuals, including those from China, Thailand, our country Malaysia, Indonesia, Philippines, as well as Taiwan, and to a lesser extent in India as well as Japan. Glucose 6 dehydrogenase deficiency, or known as G6PD deficiency, is present in more than 400 million people worldwide and mostly affected by the men. It is an X-linked inherited enzyme deficiency leading to susceptibility to hemolytic anemia. So, oxidant drugs such as primaquine, sulfonamides, as well as nitrofurantoin can act as provoking agents. So let's have a break before we continue to the last video, which we discuss more on the role as pharmacist's role in managing of adverse drug reactions.